Good afternoon, everyone. This is Dr. Claudia, neurologist here, and I'm very excited. The Neurocurious team is super excited to have two very special guests today. Everyone, would you like to introduce yourself? Dr. Lorario, you go first.
Hey, I'm Dr. Z. Lorario. I am a neurologist, board-certified neurologist, and a psychotherapist. I am currently an associate professor of neurology at Thomas Jefferson University in Philadelphia. I specialize in LGBTQ healthcare and neurology, as well as functional neurological disorder.
I'm Jessica Muñoz Cohan. I am a licensed marriage and family therapist, and I've been in private practice. My specialty is trauma.
Great. All right. So, Dr. Z, just to start, could you help us understand what is functional neurological disorders and how that differs from other neurological conditions?
Yeah, I think this is a very important question because there's a lot of misconceptions around there of what functional neurological disorder is, and we'll refer to it as FND just for easy use here. Functional neurological disorder, let's start by saying what it is not and how this term came to be. It's in contrast to structural neurological disorders. Structural meaning there's injury to the structures of the brain that we can find on tests, like an MRI scan. In functional neurological disorders, the structures of the brain and nervous system are intact, but there's malfunctioning of certain brain networks and how they communicate with each other and send signals between the brain and the body. We can't really see any abnormalities on imaging, but when we do advanced neuroimaging with functional MRI studies, we can see that there's this malfunctioning of brain networks. We kind of use the analogy with computers that the hardware is intact, but the software is malfunctioning.
Oh, that's a great way to think about it. Okay. And what are things that cause FND to happen? What's going on that makes these software malfunctions occur?
So we don't entirely know. What we do see are associations, and they're not necessarily causes, but things we definitely notice commonly among our patients. Very often there is a reported stressor or psychosocial trauma that precedes the onset of symptoms. And this is actually where some of the misconceptions come from, that these symptoms are purely psychological rather than neuropsychiatric, or that they're all in the person's head, or they're just, crazy. That's not my word. That's the word a lot of times patients are told they're,
Totally.
they are. Yeah. There's actually a brain basis, and we will see that sometimes there's sexual or physical abuse in the past history. I had a patient today who had recent deaths of family members as the stressor that occurred before this. But sometimes it's something as simple as a vaccination or other routine medical procedure. And we are not saying these things cause the disorder, but they are associated with it.
Could the recent medical procedure be perceived as a kind of a trauma?
Yes, I think chronic illness, interactions with the healthcare system are stressful in their own rights, and a person loses a lot of their sense of agency when they're interacting with the healthcare system. And especially at a time in healthcare where we're emphasizing speed and efficiency and cost savings, I just hear more and more that patients feel dismissed or that they're rushed through their appointments and things aren't explained to them in a way that's sensitive. And that's really important in this disorder because a lot of what experts believe is how the diagnosis is delivered to a person is important in how much they believe it's their diagnosis. And that's very integral to them getting the appropriate care. Because if they don't believe it's a diagnosis, they're not going to get the specific treatment for the disorder.
Definitely in my own clinical practice. So I'm certified in epilepsy. And one of the specific conditions that we treat as epilepsy doctors is, it's called PNES, psychogenic non-epileptic events. And they used to be called pseudo seizures, but we don't use that anymore because we like to acknowledge that this is in fact an actual condition. It's not a fake, pseudo being fake. It's not a faking of anything. It may not be caused by an actual epilepsy, but it is still a condition. And so really taking the time to explain to a patient, and it can take a while to kind of develop a good way of you talking to patients about this. But I found that really helps in kind of helping the patient, one, understand, two, accept, and hopefully three, follow through with different treatment modalities. So I don't know what your experience has been, Jess and Z, with kind of trying to get patients into that acceptance and then follow through.
Well, full disclosure, I've not treated FND in my private practice, but I have seen resistance, of course, when it comes to a person accepting that when you see XYZ symptoms, it is very likely that your diagnosis is AV, right? So from a clinical perspective, my question to you would be, someone walks in and they have just received this diagnosis of FND. Where do you start?
I usually start by giving an explanation, starting where we just started at the beginning of this interview. And I try and emphasize that there's a neurological brain basis to this disorder. I will kind of rule out these other things that patients may hear incorrectly, like they're making up their symptoms, stop faking it, things like that. Because we see in the brain, the parts of the brain that are involved in how voluntary a person's movements are, it's called the right temporoparietal junction. That's actually hypoactive. It's malfunctioning. So the person is not faking their symptoms. They're completely involuntary. And I think that builds some psychotherapeutic rapport, just because it shows that I believe this person and I'm validating that their symptoms are real. And I start there. I explain, in addition to saying what it's not, I also show what it is. For instance, we were mentioning psychogenic non-epileptic seizures, or what we also refer to as functional seizures. Having a person with the video of them having a seizure, or if they have a seizure in your office, you can point out discrepancies between what you would see in a person with an epileptic seizure or what it looks like when somebody's having a non-epileptic seizure. And for an example, if a person's convulsing with all their body, by definition, a person should lose consciousness because the electrical activity is basically igniting the whole brain with seizure. And so when a person can have intact memory or interact with a person during the procedure, during the seizure, or have purposeful movements during the seizure, that's really inconsistent. So pointing out those things are really important. And FND can cause more than just seizures. It could really cause any neurological symptom. And some of the other ones are abnormal movements. And so pointing out things like how when a person pays attention to their movements, they get worse. But if they're distracted by doing another task, they can go away or get better. For example, if somebody's having a tremor and they're opening and closing their hands and they're paying attention to that hand, you might see the tremor get better, or even then start going at the same rate of frequency as the hand movement. And so when you point that out to a person, you say that's characteristic of FND. That really helps things. And then I think explaining why the treatment works and that it's evidence-based, it's clinically proven, that's also helpful because a lot of the treatment is based in psychotherapy. And cognitive behavioral therapy, or CBT, is the most studied. So to say that they have a brain neurological disorder and then say you need psychotherapy, a lot of people don't want to go into that. So really explain why. And I think my own background providing psychotherapy to people with FND really helps because I feel I can explain it in a way that they really get it. And I take the time to make sure why they understand that it's important.
From your perspective, Jess, how would you characterize or use different language to really try to get at what that stressor is? Because a lot of times I find that perhaps the patient has risk factors, like you've already mentioned sexual abuse earlier in life, or any kind of abuse, as these kind of stressors. But perhaps the patient will say something like, I already dealt with that. That is not a stressor for me anymore. Or, and so for either of you, both of you, how do you break that barrier to help that patient, that person get to, okay, well, sure, maybe you're right. Maybe it's not the stressor, but what is? Something's there.
Right. Well, so in PTSD and in trauma in general, we start, like you said, with psychoeducation, and then because not everyone is ready to start talking about what happened or what may have happened, or maybe they're just still in denial, right? So we start to look for some patterns. And I'm also, I have a background in journalism. I like to start with, who, what, where, why, not the why, who, what, where, when, right? Who was there? Who was around you? Where were you? What happened when you started feeling this symptom or that symptom? See if they can begin to give me just a factual accounting, right? Before we even get to the underlying feelings or stressors. Because if we can start looking at a pattern, then we can start to maybe come around to accepting, okay, maybe you have a point. Maybe there is something else going on, or maybe there is something I haven't quite faced yet that is bringing on this other symptom that I can't explain.
Right. What about you? Have you had any particular approaches that have been particularly helpful, Z?
Yeah, this is actually one of the reasons I really enjoy working with this patient population, because there is that often in trauma, that level of denial because things are so emotionally difficult to bring into conscious awareness. But now we've hit a point where we can't ignore it anymore. It is such a disabling disorder, FND, that we're now tasked with, we need to uncover these things. There's been some studies that come out. I remember reading one where they looked at patients who were presenting for FND treatment, and they all denied trauma at the beginning of their sessions. And then through narrative interviews, trauma-based narrative interviews, they pulled out significant traumas that have happened that the person was either under-recognizing as contributory to their symptoms, or they were completely unrecognized. And in my experience, that's quite common in this disorder. And let's face it, this world is stressful. Like everybody has some trauma, whether it's something big T or little t. Like there are things that are happening that are toxic to our nervous system in all of our lives and how we structure this very complicated society. And with FND, the amygdala, the stress and emotions processing center of the brain, is actually on overdrive. It's more active and it's larger in neuroanatomical studies than those people who don't have FND. So people with FND are very sensitive to stress and emotions. So it's not even past stress past trauma, but it's the current things that are
Mhm.
perpetuating the symptoms as well. So a lot of stress reduction and mindfulness and restructuring life so that there's a better, work-life balance or just wellness balance within the life itself. Those are all really important. But I would say almost every single time when a person says they don't have any prior history of significant stress in their life and I interview them, we almost always pull something out. And
Mhm.
I don't relent until I find that. I'm
Yeah.
really persistent.
Yeah, yeah.
Yeah.
It can
Yeah.
be a challenge. Just,
Mhm.
I'm for the most part a hospital-based neurologist, and so it's hard within the rubric of, I've got 15, 20 patients to see. And you're in the hospital, with modern medicine, it's like I got them for 2, 3 days maybe at most, and so
Mhm.
it's not the ideal place. But at least I find that at least I can plant the seed. In that moment, I can at least, reduce fear that there is, in fact, impending doom, death on the doorstep, and can review, all of your tests, and this is what I've observed, and, at least hopefully get them started so that then, they can get set, and, on the path to, I always tell my patients, I want to set you up for success, and so get them in to see, someone like, either of you that can really kind of hone in and draw that out is invaluable.
Mhm.
Because hospitalists, a lot of time I find that we're like their go-to doctor, in this current healthcare landscape. It's really hard to get an outpatient physician for anything, let alone subspecialty care. So being able to set them on the path and having somebody to refer to is really invaluable. um, Specifically for LGBTQ, what do you see as the particular risk factors, or particular points that are specific to that population?
We are seeing that people who are LGBTQ identifying have higher rates of FND. This has particularly been found in transgender communities. We don't entirely know what is causing it. I think there's two main hypotheses out there as to what might be contributing. One is regarding minority stressors that this community specifically faces.
Mhm.
These are things like rejection, concealment, being in the closet, facing rejection. I mentioned
Mhm.
that discrimination, violence, victimization, all the things that are difficult and challenging about a transgender person's life. Those are chronic stressors. And that type of chronic stress is neurotoxic and can influence important brain structures, as we've seen. And so that's one of the main hypotheses, is called the gender minority stress and resilience theory. It was originally
Mhm.
coined by Elon Meyer back in the early 2000s. Um, and it's been well studied now and kind of applied to many neurological, biological, and psychological disorders. So that's one thought, that there's these additional stressors that the community faces that are beyond what cisgender and heterosexual people face that may sensitize them to having these disorders. Second is, there's questions regarding sex hormones. And this is
Mhm.
not just in transgender people, but we see a predominance of FND in women. It's
Mhm.
3-to-1 female to male.
Yeah.
We don't entirely know why that is. There might be higher rates of trauma and traumatic experiences being a woman in society, but there's
Mhm.
also some evidence that and belief that estrogen may play a role in this disorder's pathophysiology.
Hmm.
So we're starting to study these things. There's not a lot of data out there, but those are kind of the two main hypotheses that I see being studied right now.
That's crazy. Okay,
That
I'd
is
never.
interesting.
Yeah, I had
Yeah.
never thought of hormones as playing. So would it?
But that would
Yeah.
make sense.
Oh, totally.
Because with trauma, and you see the release of certain chemicals in the body, right? So it would make sense that it's kind if we are dealing with trauma, then
Yeah.
some kind of
Cascade is
cascade is
happening.
happening.
But then why more
Women?
women to male ratio. And then Z, are you finding it in the trans community? Is it more with male to female or female to male, or is it an even split? Do we know?
Yeah, and so that's an interesting question because it seems to be more assigned female at birth. So these are people who are
I
trans
see.
men, trans masculine,
Yeah.
trans boys. And we do see it in trans women and trans feminine people, but it looks like people who are assigned female may be at higher risk.
Okay.
As one example, there was during the pandemic an outbreak of functional tic-like behavior. So people were
Hmm.
very complex
Remember that.
vocal and motor
Mhm.
tics,
Yeah.
and they were functional, and we were seeing that all over the world. And we were definitely seeing an overrepresentation of transgender adolescents and young
Oh,
adults
okay.
in the population.
Mm.
And about 90% of them were assigned female at birth. So there was definitely an overrepresentation of
Mm.
assigned female transgender adolescents and young adults who are presenting with this symptom. And so, like, that is something that, we don't know why that was. We're starting
Yeah.
to study it, but that's one example. And in one study, and this was probably the highest reported, but in one study, 43% of the FND subspecialty clinic were
Yeah.
trans or non-binary identified.
Oh, wow. That's
Very
crazy.
substantial minority.
Yeah. All right. Well, see, as physicians, therapists, educators, what can we do to provide more affirming, effective support for these young people or, adults at any point in life? But I just feel like younger folks seem to be much more vulnerable. But, who present with conditions that we are, feel confident, oh, it's FND. What can we do as clinicians, caregivers to really, put them on a positive track
To support
Yeah.
them.
Yeah.
Mhm.
Yeah, we all are here to provide the most sensitive and compassionate care, and there are certain things that may not be intuitive but are really important. And there's studies out there that affirming healthcare providers and positive experiences actually reduce depression symptoms, reduce suicidal thinking. Like, these are interventions that actually save lives. So if our job as doctors is to save lives, these are things we can do. And conversely, if we don't do them, we're actually potentially doing harm to a person who,
Yeah.
that is vulnerable otherwise. Some of the interventions I mentioned in those studies include just using a person's pronouns.
Oh,
And
okay.
Okay.
that's a very simple intervention. If you hear another health provider or a family member misgender, which is use the wrong pronouns for a transgender patient, you can then model the correct pronouns, like being, well, she said that during her
Yeah.
symptoms, she was experiencing seizures. So you can kind of model it. If it's another health provider, not to embarrass them in front of other people, but to take them aside afterwards and be like, oh, this is a woman. She uses she, her pronouns. And I think, having some allyship to do that work so the trans person doesn't have to correct their providers is very helpful in their care. Chosen names are names that a person identifies with, even if it doesn't match their legal name. And it's an affirming name. So as an example, somebody whose name is John now, goes by the name Joanna. I see a lot of issues with this in healthcare because for legal reasons, our electronic health records use the patient's name on their insurance card, and for various reasons, it may not reflect their chosen name. So there are places in electronic health records to use a preferred name, and I don't like that because it's not preferred; it's their name.
It's their name.
They just happen to be transgender, and it's their
Yeah.
name. So it's not preferred; it's their name. So if you have a place where you can do that, definitely enter it. I think most transgender people realize what's happening, but even I apologize that this is the case. And this is the reason why, this is happening. It's the name on the insurance card. Could help if the person is upset that the wrong name is being listed in the electronic health record for whatever reason.
Yeah.
Keep in mind with adolescents that not all of them may be out. So, if
That's
you
right.
suspect they may not be out to their family, ask them permission before you change their pronouns or anything like that. Also in the chart, having transgender in the chart, which often ends up in the chart if somebody comes in as identifying as transgender, that will actually potentially introduce bias into anybody else who reads the chart.
Yeah.
And
Yeah.
there's this phenomenon, trans broken arm syndrome, which came from the concept that people would come to the emergency room, say, with something unrelated, like a broken arm, and in the requisition form for the radiologist, they would put transgender. And then that would influence treatment care because everybody would know this person's transgender, whether or not it's relevant.
Irrelevant at all.
And they wanted
Completely
people to
irrelevant.
know.
Yeah.
Okay.
Oh,
Yeah.
wow. And, I have seen that. It's, if somebody comes in for stroke and it's like transgender and blah, blah, blah. And I'm like, okay, who cares? I mean, under some circumstances, obviously it's, is the person hypercoagulable? There are reasons to care about the patient's hormone status, but yeah, it's not always the case for
Yeah.
sure.
And
Well,
that's
this has
another.
been, yeah, go ahead.
Oh, I was just going to say, because I am also a vascular neurologist, like a lot of times when that happens, the reflex is to stop the hormones because there's fear of hypercoagulability, but
Yeah.
to not do that because of the many psychological benefits.
Absolutely.
Informed
Yeah.
consent would discuss the pros and cons of doing it.
Absolutely. Yeah. I haven't actually come across that particular, but yeah, it would definitely, at least from my point of view, would merit a really deep dive into the literature before doing anything to somebody's, hormones. I'm glad you mentioned that. That's actually really, really helpful to know.
That is helpful.
Just as a physician. Wow. Well, this has been really, really super informative and helpful, fascinating. Where can people find you, Z, if they want to know more about you or learn more?
Yeah, you could follow me on X at MP Lerario, M as in Mackenzie, Page Lerario, Lerario. And you can find my practice. I am currently based in Philadelphia, PA, in Center City, Philly, at Thomas Jefferson University. I am also licensed in neighboring states and provide telehealth through the same program. So for people who are looking for an FND specialist, we definitely are building up a referral network for physical therapists, psychotherapists in the area who do treat the disorder. And I'm happy to see any referrals at my practice as well.
Awesome. Jess, where can people find you?
Oh, that's simple. My name is Jessica Cohan. So it would be jessicacohan.com, COHAN.com.
Excellent. And as always, I'm Dr. Claudia. Thank you everyone for joining me today. This has been amazing. And Z, you're our inaugural interviewee. So thank you so much. Thank you. It's been really wonderful. Do you have any questions for us or anything you need from us?
No, I'm just glad for the platform for advocacy because
absolutely,
it's such a lesser known disorder, and it's the second most common reason somebody comes to see an outpatient neurologist. So having more people be aware of what it is important. So thank you.
Wonderful. Hope to talk to you again.
Okay.
It's been awesome.
Have a good evening.
Thank you.
Thank you so much. Bye-bye.